Good afternoon, everyone. Welcome to the ACSM Brown Bag and Science webinar. We're thrilled to kick off the 2020-2021 year with a presentation by Dr. Garrett Ash. You'll hear more about Dr. Ash in a minute, but first, we want to make you aware that this year we will use the Brown Bag series excuse me, to highlight various ACSM regional chapters. We'll start each Brown Bag with someone from the regional chapter. It might be a leader, it might be a student, telling us a bit about some of the activities of the chapter. Then the presentation will be from a member of the chapter. Today's presenter is a member of the New England chapter. So first, a few housekeeping items. Our presenter will give us a 25 to 30-minute talk, followed by question and answer. Please type your questions into the question area on the GoToWebinar screen, and we'll take as many questions as possible after Dr. Ash's talk. If you have trouble hearing or seeing the presentation, it is likely due to your internet connections. Please log off and log back into the webinar. We will record the presentation, and within about 48 hours, we will send you the link to the recorded version. So again, thanks to everyone for joining us today. I'm going to turn this over to Paul Gallo. He is the ACSM New England Chapter President. He's also the Director of Exercise Science and Wellness at Norwalk Community College in Norwalk, Connecticut. He's going to tell us a bit about the chapter and introduce Dr. Ash for us.
Thank you so much, Lynette. Good afternoon and welcome. Prior to introducing our presenter for today's webinar, I would like to discuss an upcoming event for the New England chapter of the American College of Sports Medicine, also referred to as the NEACSM. I am very excited to announce that the NEACSM will be hosting its first ever virtual fall conference entitled Exploring Diversity in Exercise Science and Sports Medicine, Research to Practice. As a regional leader in quality programming and research, we look forward to reaching a larger audience with this year's virtual programming. The fall meeting will be a combination of pre-recorded content and live events where participants will be able to interact with all speakers via Zoom webinars. Over 40 sessions of pre-recorded content will be made available from October 1st through December 4th, and the virtual live sessions will be held on October 15th and 16th. The conference provides attendees with 9.5 CECs or 6 CMEs. Our program will include keynote lectures from Dr. Sherry Blowett and Dr. Patty Ekakakis, as well as a lineup of dynamic, invited, and general session speakers. There will be a wide range of topics presented as tutorials, workshops, and symposia. Registration fees for the conference are $95 for non-NEACSM members, $65 for non-member professionals in training, and $20, yes, $20 for all students. Professionals who are members of the NEACSM will get a $15 discount. For more information and to register for the conference, please visit us at www.neacsm.org/fall. We hope to see you there. Now I would like to introduce our speaker for today's webinar entitled Exercise Support for People with Type 1 Diabetes plus Sedentary Lifestyle and/or Overweight. Dr. Garrett Ash is a postdoctoral fellow at the Veterans Affairs Connecticut Healthcare System and Yale University Center for Medical Informatics. His work focuses on using wearable biosensors and data analytics to build interventions that promote improved lifestyle and clinical outcomes across a wide range of populations, including youth and adults with type 1 diabetes, young adults with heavy alcohol consumption, and adults with heart failure. He is also the lead organizer and proceedings author for an annual series of ACSM panels to provide input toward the International Federation of Sports Medicine's efforts to establish global standard for wearable devices in sport and fitness. Garrett, thank you for being here today, and the webinar is all yours.
Thank you very much, Paul and Lynette, for having me on the webinar today. I'm excited to present. So I'm going to start with just some definitions so we're all on the same page. This may be review for a lot of people. The difference between type 1 and type 2 diabetes is shown here. The risk factors for type 1 diabetes are genetic, viral, or unknown. It's not clear why people get the condition. Type 2 diabetes has a large lifestyle component related to physical inactivity, poor diet, and excessive weight. There are also some genetic factors that play a role. Type 1 diabetes destroys cells in the pancreas and prevents the pancreas from making enough insulin. Type 2 diabetes decreases sensitivity to insulin by the liver and muscles. So there's no insulin present in type 1 diabetes. Type 2 diabetes, the pancreas will make more insulin in the early stages to compensate, and then less insulin in advanced stages as it becomes burned out. Blood glucose is elevated in either case as a result. Type 1 diabetes presents with acute symptoms, diabetic ketoacidosis, and the patient will be immediately hospitalized until treatment can be started. Type 2 diabetes develops gradually. Type 1 diabetes must be treated with insulin. Type 2 diabetes can be treated with oral medications and or insulin. Diet and physical activity are very important for type 1 diabetes. They can improve blood glucose control along with insulin, and they can mitigate the cardiovascular comorbidities of the disease. People with this condition have an 8-fold higher risk of cardiovascular related mortality, so exercise is very important for them. Type 2 diabetes, weight loss, diet, and physical activity can mitigate the condition or even reverse it in some cases. Metric of success is glycosylated hemoglobin, which reflects the chronic elevation of blood glucose over the past 3 months. In type 1 diabetes, it should be kept below 7 to minimize long-term cardiovascular risk. It should also be kept low in type 2 diabetes, and especially low values can even reverse the condition. So type 1 diabetes affects not as many Americans as type 2 diabetes, but still a sizable number, and it's worthwhile certainly research to improve care of the condition. So exercise for type 1 diabetes is complicated. I've done my best to simplify it here using guidelines from a consensus statement in the American Diabetes Association. But basically, exercise can make blood glucose go too low or too high. So this gets very, very confusing. The response varies based upon a lot of different factors shown here. What the starting level is, the characteristics of the exercise, how insulin has been taken before, during, and after exercise, carbohydrate supplementation to increase blood glucose level, and people who are more physically fit have greater sensitivity to insulin. This can be a factor also. So it's very important for these participants to plan ahead in adjusting insulin or carbohydrates, monitoring blood glucose and trialing and erroring what works, watching for signs of hypoglycemia, which can be dizziness, nausea, fatigue, and other symptoms like that. And if blood glucose is high, they should test their urine for ketones. If there are ketones present, it's a sign of ketoacidosis occurring, and it's a process that you do not want to be happening while exercising. And so that's the contraindication to exercise. So they should be wary of exercising if blood glucose is high, but it's not an absolute contraindication. The need addressed by my work is that most interventions for type 1 diabetes target that goal of reducing A1C. And a lot of that relates to better strategies with diet and insulin. But there's a lot of other modifiable disease risk factors present. As I said, excessive weight is not part of the etiology of type 1 diabetes, but over 60% of them in the US are overweight and also have other risk factors too, and a lot are sedentary. So there's a need for interventions addressing these that are not just addressed by better use of insulin and diet to control high blood glucose. And guidelines that I showed lack data on promotion of exercise to those who start from sedentary or low levels. So after this talk, I'd like you to be able to identify barriers to physical activity among youth with type 1 diabetes, describe the successes and challenges of a program that I started to address these barriers, and then critique my plans of a mobile intervention addressing these challenges. So the barriers to physical activity for type 1 diabetes are shown here. As I said, that problem solving and adjusting diet and insulin can get very confusing and complicated. The careful planning that is required around these tasks mean a youth with type 1 diabetes cannot just say, hey, let's go play volleyball, or an adult can't say, hey, let's go for a brisk walk. This limits activity. And then fear of the symptoms of hypoglycemia that I mentioned psychologically can be a barrier to exercise. Social barriers, a lot of physical education teachers, peers, even physicians, it's scary to say, will have an overestimation of the limitations that diabetes places on exercise. And the physician or the personal trainer might say, have you tested your blood sugar at least 3 times today before starting to exercise? And or you can't do this harder exercise. And the patient will say, I know that, I know how to manage my diabetes. But these social barriers can be a limitation as well. And then the built environment, just like it limits all of us, and especially in this day and age, but having access to safe spaces or having a family environment that promotes exercise is also important. So now I'd like to describe the successes and challenges of my program addressing these barriers. I'd like to acknowledge all the co-authors who contributed, and this was published last year in Pediatric Diabetes. This was funded by the New England chapter of ACSM Young Investigator Award. Feasibility and safety of a group physical activity program for youth with type 1 diabetes. So we developed intervention components to address each of these barriers or strategies. We had diabetes self-management education to address the problem solving. We had stress management and relaxation techniques to address the fear of hypoglycemia. We had peer group classes. The idea of creating a comfortable space to practice exercise safety for diabetes. So if they had any reservations, for example, how to test blood glucose in a class of people who do not have diabetes, they could practice it among their peers, then apply those skills in the real world. And then we also had communication and conflict resolution discussions to further help these social skills. And then we had the parents and caregivers also participate, not just the youth, to encourage that home environment supporting exercise. Just logistically, here's what the program looks like. We enrolled teens with type 1 who were sedentary. We met once a week for 12 weeks on Saturdays with the peer group approach. We had exercise and these other components that I mentioned. It was held at a gymnasium of the local school. This is the schedule we would follow. We'd start with blood glucose checks. They'd fill out a weekly log so we could monitor their blood glucose over the whole week and see if any exercises of ours or others that they were doing outside of the classes were having a safety impact. Then the teens would exercise while the parents would have a group discussion, and then the groups would switch. So how did the safety check work? They would test their blood glucose. They were provided with carbohydrate supplementation. We had a rule: if their blood glucose was less than 100 milligrams per deciliter, they would take 15 grams of carbohydrates and wait 15 minutes and retest before initiating the exercise. Different things work for different patients, but when we had a group of 10, 12 participants in one room with 15 minutes to perform this check, this was the standard rule that we followed. And then if they had issues with adjusting their insulin, in particular if their blood glucose showed up in that high range, they were assisted to contact the diabetes provider on call at Yale New Haven Hospital for further assistance. It's difficult for trainers and fitness staff to get involved with insulin dosing decisions. So we leave that between the patients and providers, though we can provide access to it. They were encouraged to follow safety guidelines and in particular be cognizant of symptoms of hypoglycemia. These are some exercises we did. We did dynamic warm-up routines. We did body weight resistance exercises like lunges and wall push-ups, agility drills, and plyometric exercises. So I should note these were taken from the Yale Bright Bodies program, which is a weight loss promotion program for inner city minority youth with or without diabetes. And we just used the exercises from this program because they've been found to be very appealing to youth who are just starting or just getting back into exercise. And we found our participants really enjoyed them as well. The non-competitive games are also a really important part of this routine. So a game like a balloon relay where the group has to keep a balloon in the air and advance it all the way across the gym, playing tag, so as people get tagged and become part of the team trying to catch everyone else, or team juggling. And they also report really liking these non-competitive games as opposed to, say, playing basketball or baseball. Then the classes with the education component had a primary focus on exercise tips for diabetes, such as the guidelines I showed at the beginning of the presentation. There was a secondary focus on nutrition, healthy eating for all kids, things like fruit and vegetable consumption, balance of carbohydrates, proteins, and fats. There was also some diabetes-specific content, such as effective counting of carbohydrates to better manage with their insulin. These were facilitated by a certified diabetes educator. And then about 2/3 of the discussion classes focused on this coping skills component. Some of it was things like I said, mindfulness meditation, addressing things like fear of low blood glucose. But then we also had discussions and role playing. I should add a lot of this focused beyond just the topic of handling social situations related to exercise. A lot of it was just on sharing their personal stories and experiences with diabetes. What was it like the first time they stayed in the hospital when they had ketoacidosis? How did they feel? How do they feel about their situation? How do they cope with their chronic condition? A lot of times it was the first time these youth had ever talked to another youth who had type 1 diabetes. And it's challenging to convene these groups. First of all, because it's only seen in about 1 in 500 youth, so maybe that's 1 or 2 per every school. And 2, a lot of times these youth do not want to come together and just talk about diabetes, but we sort of brought them together over a non-diabetes topic of exercise, and then they would stay and bond in these discussions with the peers they had, connections they had formed during the exercise classes. Then these also included communication skills and conflict resolution discussions, like I said, with role-playing scenarios of what do you do if you encounter a situation where you're, say, uncomfortable testing your blood glucose, and play out skills to cope with that. These were all taken from a prior curriculum developed at the Yale School of Nursing called Teens Cope and Teens Connect, which delivered online coping skills training and in-person coping skills training to a wide variety of participants. The parent discussions were more open-ended. They would express challenges related to diabetes management and receive education on these topics. And then we also had, so they would say, I'm worried about my child having low blood glucose at night because I'm worried I can't check on them. I'm worried they won't know that they're having low blood glucose, and we'd talk about strategies for addressing that. Then we also had exercises that were acceptable to this age group. So the aims of my study were to just evaluate the feasibility and safety of this intervention, and then estimate pre-post effects on outcomes we wanted to look at, like physical activity behavior and other exploratory things like nutrition, psychosocial things like fear of hypoglycemia, clinical and fitness outcomes. It's a very early study, so we just included one group with a follow-up immediately post-treatment at 3 months and 4 months after that to see if the effects were sustained. We did not include a control group because the goal was just to see if the study is feasible and safe and what modifications we might want to make before running a larger study. So I'd like to note a few things about the participants we enrolled. They were racially and ethnically diverse. They were diverse with respect to gender. Less than half of them were using insulin pump technology, whereas about 2/3 of the overall population uses this technology. So they were not uptaking diabetes technology as rapidly as the rest of the population. A lot of them were still using the more basic method of self-injections. I mentioned a goal of glycosylated hemoglobin is 7%. So the average was well above this. So that shows this was a population in need. And their over half of them had income less than $40,000 a year. Their body mass index on average was in the overweight to obese range. So again, overweight and obesity do not contribute to the etiology of type 1, but a lot of people with type 1 diabetes have overweight or obesity. Their blood pressure and cholesterol were within normal ranges. Their score on the PACER test or the BEEP test shuttle run got them to around stage 3 or maybe stage 4 on average. This is bottom 25% for this age and gender, and we actually modified the starting speed to be even slower than the standard. So this was a group in need of increased physical fitness. We measured physical activity with accelerometers, and they were on average well below the recommended 60 minutes per day, very little exercise in 10-minute bouts per week. Their self-reported screen time was well above the recommended 2 hours per day, and their fruit and vegetable consumption was low, which we measured with food diaries and NutriCheck software. During that pre-exercise screening that I mentioned, there were few, if any, times that they showed up with blood glucose less than 100. That makes sense because, like I said, their blood glucose was chronically elevated, so you wouldn't expect that to be a major concern. There were a good number of times they showed up, so out of 169 total person sessions, 25% of those times they showed up with blood glucose in that high range where we recommended ketone testing. However, there was very little presence of urine ketones, so the exercise was almost always feasible and safe, despite showing up with the elevated levels. Then this shows tracing blood glucose over the course of the sessions. Each line represents one of the 18 participants in the program, and the left side is their average glucose they arrived to the sessions with, and the right side is the average glucose they ended the sessions with. So there's a lot of factors that are impacting the blood glucose. It has variation by the time of day. It has variation with food and insulin taken before exercise, and the exercise may have some effect on the blood glucose as well. But the point I wanted to make with this is that although there were a lot of participants showing up with chronically high blood glucose, with acutely high blood glucose, I should say, they ended in the target range or still above, but we had almost no instances. There was just one time where someone reported had low blood glucose, and it was quickly resolved. It was a minor instance. So some metrics about how feasible was this. We approached about 100 participants and 18 enrolled. About half of them attended 8 of the first 12 sessions, which we considered to earn a completion certificate. A greater proportion attended the data collection completion, so we could get complete data. The cost was rather high of completing one participant. A lot of this related to logistics of transportation. We recruited for about like a 30 or 35 mile radius around New Haven just to get a critical mass to have a group. So we supported taxi fares and mileage costs for these participants to attend. We were not able to hold sessions twice per week as we had hoped, and as was done in the Yale Bright Bodies program to promote weight loss. But we were able to hold them once per week on Saturday mornings. That's when we were able to logistically convene the group. But this required extra money to keep the school open. It required staff to do overtime. And we always had 2 nurses and 2 exercise physiologists running the program, even when there were just 4 to 9 participants at any one session. So that, that cost of staffing added up. And I'll show data on the 10 completers. So this is not everyone who was enrolled, but just people who completed. They reduced their systolic blood pressure over time. Their LDL cholesterol increased, but remained within normal limits. And their scores on the PACER test improved by about 25%. So we were very glad to see this. When the full cohort was analyzed by intention to treat, we saw no changes in any variables. There were also no changes in any of the physical activity or nutrition behavior variables that I mentioned. So they didn't really increase their exercise outside of the sessions. So the successes were that the discussions and exercises were appealing for children, and they were safe with low instances of hypoglycemia, and we chronically improved fitness and blood glucose. The challenges were these participants arriving with high blood glucose, requiring us to take time testing urine ketones and sometimes contacting the diabetes provider on call. And there were no improvements to the chronic levels of any of these variables and just the logistics, as I mentioned. So we thought about this, and we thought there really would be a good need here to establish a mobile support intervention to address a lot of these logistic problems. And perhaps we were even seeing into the future, unfortunately with COVID, there's even more need for these mobile interventions. So I'm in the very early stages of this, and I'd like you to be able to critique my intervention. So we have different components in a mobile intervention, but a lot of the same barriers exist. I should note our mobile intervention is targeted at adults. It's common in clinical trials to, even if you have a tool that you want to be usable for a wide range of people, it's good to start with the range where it's most likely or most feasible to be effective as what we call proof of concept. And then that can be extended to other populations. So for a mobile app, we feel it's easier to transmit the types of exercise that adults do to a mobile app, but we hope to eventually make an app for children as well. We address the environmental barriers, obviously, by having home-based routines to prevent issues around quarantine or just convenience of attending exercise sessions. We don't have a peer group, but we can have a coach with specialized expertise and sensitivity to diabetes who can provide person-centered motivational enhancement and coaching. And then we have these devices called continuous glucose monitors, which allow blood glucose, they test blood glucose automatically every 5 minutes. So it gives this nice holistic 24-hour picture of blood glucose. So it's much more supportive than the finger stick checks that most of our youth in the previous study were using. So this can help a lot with the self-managed problem solving and assuage fear of hypoglycemia. And furthermore, they wear these other devices, the Apple Watch, and they keep a diary of mood states and sleep quality. There's a theory called health feedback, which states that if people are provided with feedback on multiple health behaviors at once, they can start to see intersection among these behaviors, and it motivates them to make multiple changes. So that's why we added these additional biosensors. I'll just say a little bit more about continuous glucose monitoring. It has this huge benefit of identifying trends, not just snapshots. So it says your blood glucose is 104 and it is trending downward. That's a lot different than 104 and trending upward. It links these trends to events here. So these vials represent when the person took insulin, and the knife and fork represent when they ate. This is the blood glucose level, and this is time from midnight to midnight. So they can start to link these trends to the events that are occurring. It also generates summary statistics. So rather than just an isolated test, what was the average over the whole day? How much did it vary? Overall, how much time were they spending in this high range that leads to chronic elevation, to chronic hyperglycemia and long-term health outcomes? How much were they in range? How much time were they at risk of hypoglycemia? And people have reported this increases confidence and motivation to pursue healthy lifestyle habits, but it's been very limitedly applied to promotion of exercise. So the aim of my pilot study is to evaluate feasibility, acceptability to participants, and safety of a mobile exercise intervention for adults with type 1 diabetes. So I've designed this study with my partner's Glucose Zone. I should say Glucose Zone has supported the study, and it would not have been possible without them. They have designed a customized mobile digital application which supports data collection as well as exercise intervention delivery. So the format of the study is the participants, who are adults with type 1 diabetes who are currently exercising less than 3 days per week, and on average they were exercising about 0.5 to 1 times per week when they started the program. They do an orientation with that digital coach that I mentioned, and then monthly consultations about exercise where they provide personalized feedback from the continuous glucose monitors and the Apple Watch and other devices. They have on-demand access to these different components, which I'll describe on the next couple of slides, provided by Glucose Zone. They complete a daily mobile diary with software we have at Yale called Qualtrics, and they wear the devices, as I said. A major component of the on-demand support is exercise videos. They have about 200 different videos here. You can try the app, Glucose Zone. It's actually available free right now to anyone living with diabetes during the pandemic. There's also a normal subscription fee, ranges from $7 to $13 per month. The videos can be filtered down according to difficulty levels. Level 1 we found to be a very good level for our beginning exercisers. To give a context of the other levels, I have a moderate level of physical fitness. I exercise about 45 minutes a day at moderate intensity. I found the level 2 videos to be good for the resistance component of my exercise. Level 3 videos were challenging, but I was able to sometimes complete them. They can select the duration, and then they can select from all these different categories for the type of exercise they want to do. There's opportunity to do chair-based exercises or other mobility accommodations, and a lot of them can be done with no equipment to really facilitate the home environment. They can also do things like freeze soup cans or freeze water bottles or use soup cans to support exercise. So this menu filtered the videos down to 6 choices, for example. And then there's texting support where they can ask questions about exercise for diabetes and receive support. They can also enter their starting blood glucose level and have a workout recommended. So broadly speaking, continuous aerobic exercise can lower blood glucose, and high intensity interval exercise can raise blood glucose. Not for everyone, not one size fits all, but this can just give some general guidance based on what level they're starting at. There's also certain muscle groups when emphasized will lower or raise blood glucose. On the mobile diaries, they're asked to report what were their top barriers to exercise on days they did not, and also their sleep quality from the prior night. then on the monthly consultations, there'd be a visual display of the data. And I'm just going to briefly show that here. So this is an example of data from one participant in the study. We start by overviewing their exercise metrics. Just for the each month that they're in the study, how hard were they working on a Borg scale? What difficulty levels were they using? What was their heart rate range? Were they reaching? How much volume did they reach? We remind them of recommendations. Then we give those blood glucose statistics about continuous glucose monitoring that I previously mentioned, and we target, tell them what the targets are in that area. Then we start to show the overlay of the blood glucose with the exercise data. And again, this is the aspect that using just one app for glucose or with exercise will not give in isolation. We give all the statistics of the exercise bout, so the intensity, duration, the type, carbs and insulin taken in close proximity to the exercise. And then we show the continuous blood glucose tracing over this 24-hour period relative to the target ranges. And so patterns sometimes emerge here. We do not advise the participants what those patterns are or how to treat them. Similar to the youth, we keep the insulin dosing adjustment decisions between the participants and their providers, but they may see patterns in this that they become motivated or decide to adjust on their own based on things their provider has told them, or even discuss it with their provider. So for example, having a relatively large insulin bolus on board before exercise, and following this, there was an episode of hypoglycemia, they might want to investigate if there was a link between these events. We also show them an average non-exercise day for comparison. And we do this week by week for the whole period covered. And then we quantitatively show the blood glucose statistics on the exercise versus the non-exercise days. Again, not making the inferences ourselves or making clinical recommendations, but if they see things like for this participant, oh, I spend less time in the high range on exercise versus non-exercise days. Again, don't know if this is because of exercise. It could be because on days their blood glucose is in better control and they're less worried about ketoacidosis, they're more inclined to exercise. But if we can give them these data, they can decide what to do with the information. And then we also ask them from this information they report in the surveys, for example, how well did you sleep last night? How worried were you about hypoglycemia? We can show them on days after you exercise versus days that you don't, what were your levels of worry and what were your sleep quality, so they can, again, make inferences as they desire about that. And then we recap for them their barriers to exercise and discuss with them strategies to overcome these barriers. All this is delivered in a person-centered style. So we ask them things like, you know, how does this information seem to you? Were you aware of these patterns? Are there anything, any decisions you are thinking about making according to these patterns? And then we'll provide further information and tips as it's pertinent. But the point is we're seeing how they interact with these data, and there is a human component to this delivery. Just very preliminary, I can't report results on this yet because we're still collecting the data. It's going to be a study of 20 people overall, but it's just to show you who we've recruited initially, a wide age range. It is not a diverse sample, and we're thinking about strategies for addressing this. A lot of the recruitment we do is through social media, either paid advertisements on Facebook or postings to diabetes groups by either members of those groups or by us ourselves. The control of glycosylated hemoglobin at the start of the study is very wide ranging, as you can see by this standard deviation. So on average, they're right at or slightly above those that target range of 7 that I mentioned, but we have people here ranging from very good control to very poor control. And like I said, because type 1 diabetes is not lifestyle based, there's not a direct correlation between exercise and glycemic control. So we have people in good control with an A1C value of in the 5s or 6s, say, that still want support to exercise more. And we have people who are in poor control who also want support to exercise more. And I would say very similarly about the BMI levels and the range of BMI represented in the study. I'm proud to report we've had strong adherence to all the different procedures that I documented so far. So the feasibility has been good, the safety has been good, and the participants have reported overall being moderately satisfied with the program. Specific components of the program are shown here. So you can see their top rated satisfaction is on the diabetes devices. That's expected. We live in a burgeoning age of diabetes technology, and it makes sense that they would really view these devices positively. They reported these monthly feedback calls that with the style that I showed to be very helpful. The more standard orientation calls and exercise videos, again, this is all commercially available also right now, were reported as helpful. Then the least helpful components were the text messaging and the daily diaries. So the things we provided them on a daily basis were reported as less helpful than these things we did monthly. So we're looking into ways we can improve upon this. And then what about the monthly calls helps? I would just like to note that they were particularly interested in discussing the intersection of exercise and blood glucose, as well as exercise by itself, but then the intersection of exercise and sleep also. So this intersection of exercise with other health behaviors was popular to discuss along with exercise itself. So in conclusion, all these protocols are safe and have feasibility metrics meriting further investigation, even if we don't know exactly the magic formula yet to actually achieve our goal of increasing exercise behavior. Clearly, we should be targeting more intensive interventions, whatever we decide, and the integration of the continuous glucose monitors is feasible, acceptable, and should be further pursued. These studies also facilitate a lot of bioinformatics because we collect blood glucose data every 5 minutes, we collect all the insulin dosing, and the we also collect the Apple Watch heart data every 5 minutes alongside that. So we just got these tremendous volumes of data, and we can start to do analyses that are otherwise not possible. And we could also use these analyses to inform ways to automate the support that we give. So for example, if we can tell on certain days that are better or worse for exercising, could we provide customized feedback to help coach exercise in that way? And again, that could increase the frequency of contact as well. So I'd like to acknowledge my investigative team from both these studies from a variety of institutions. They all made essential contributions. And I'd also like to acknowledge the students from a variety of institutions that made great contributions to this work as well. My funding, as I said, came from the New England chapter, a group within Yale New Haven Hospital, Children's Hospital, some internal funds from Yale, and the Michael and Rosemary Ryan Pediatric Diabetes Research Fund. Thank you for your attention, and I look forward to a good discussion now.
Great, thank you, Garrett. That was a great presentation, chock full of really interesting work that you're doing on the work you're doing is really interesting. We want to remind everyone you can enter questions into the GoToWebinar question area. And we're going to spend a few minutes now with Dr. Ash doing Q&A. And Dr. Gallo is also still on the webinar. So if you have specific questions about the upcoming regional chapter, you can ask those questions as well. So the first question we're going to ask to Dr. Ash, someone is asking, do you provide an other selection as an option related to the barriers of exercise? So for example, if the barriers that are listed don't apply, is there an other thing that can be checked where they can then type in their barrier?
Excellent question. Yes, we do provide this. Something else we find has been really helpful is a question at the end of the diary, which states, besides ones we have already discussed, have you encountered any barriers or challenges so far to participating in the study? And we find this if they're having glitches with the app, or if maybe their device is having a malfunction, something that they would normally maybe just cast to the side and say, I'm not going to deal with this. We've gotten a lot of good feedback through that question as well.
Great. Here's another question. This person says, there are qualitative studies out there suggesting that many physicians don't encourage and even discourage exercise in patients with type 1 diabetes. Do you think adding a piece for physician education around type 1 diabetes and exercise could help with the psychosocial component?
That's an excellent question. You must have been reading our emails. We are thinking about doing this. So something I will point out is that the continuous glucose monitoring apps, such as Dexcom Clarity, that show blood glucose, they don't have this major focus on exercise that we do, but they do have a little bit on exercise. Those are designed to share data with the clinicians, the clinician will print out a 2-week report with all kinds of summary statistics and trends identified, and they'll discuss that with the patient at the appointment. So I think there's tons of potential with these apps to have a clinician share feature. And we just have to, interview the clinicians and see how they liked using it. It's also noteworthy that right now the usage of the apps, the existing apps for continuous glucose monitors, are used mostly. A lot of patients will only use them to look at the daily interface of just what's my blood glucose now and is it going up or down. And they won't, those summary statistics, they will just share them with the providers and not look at it themselves. So we want to encourage them to use them more themselves as well through the interventions that we're targeting. But the point I want to make is that clinician share feature is very widely used in those other apps. So that gives promise that we could create something like that also.
Great. So you mentioned the first study that you described, you mentioned what the cost was per person. Do you have any sense yet about the cost per person when you're using the app versus the in-person program?
Yep, excellent question. Much lower. The app is commercially, the services offered by the app have a cost of $13 per month. The equipment that people often buy, they buy this themselves, but if we were to provide that, that runs from $10 to $50. I think the continuous glucose monitors can be a cost, but thus far, almost everyone who enroll in the study has had their own continuous glucose monitor that's already covered by their insurance. And then there's use of the Apple Watch. An Apple Watch runs about $200. But a lot of this could be done without the Apple Watch device and by self-logging the exercise. We find really, for these resistance exercises that we're prescribing here, the heart rate is not the best indicator of intensity anyway. So just by logging on the application when they exercised and then asking them for their rating of perceived exertion, we really get a lot of valuable data for those reports. So I don't have an exact total yet, but I hope I've just illustrated that a lot of these components are either coverable by other sources, not absolutely necessary, or very reasonable.
Yeah, absolutely. And we just had a follow-up question. The person is asking if the continuous glucose monitoring systems are widely available across the socioeconomic spectrum. Can most people get these if they want them?
That's a very good question. So I'll say they're used by 30% of people with type 1 diabetes overall. There were participants. I'm unfortunately not like an expert on the economics of it. I'd be glad to look up some of that information. I think it's important for us to consider if we're going to expand the diversity of participants we enroll here. I will say a lot of participants in our study on youth who were a lot from that lower socioeconomic class. Some of them were being referred for continuous glucose monitoring and being either not necessarily during the study they got access to it, but in the near future they were expected to have access to it. So it is possible. I'd be glad to look up some more like advanced economic statistics and provide that for the group.
Great, thank you. So another question says, the first study seemed to have more of a aerobic style exercise program, whereas the pilot study has more of an anaerobic style exercise program. Was this decision made based off physiological responses differing in different styles of exercise, or has that been examined in relation to those cardiovascular risk factors, aerobic versus anaerobic in this population?
That's a great question too. So I should say, I know I didn't give a ton of details about the specific frequency, intensity, time type of the exercise videos shown here. They do have a substantial cardiovascular component to them with dynamic movements. And so we do see heart rates in the 60 to 70% max range. We do have the curriculum is in accordance with American Diabetes Standard recommendations, which are for a combined workout program, because the cardiovascular exercise can have a major impact on the overall heart health. Physical fitness is also correlated with cardiophysical fitness is correlated with lower incidence of mortality, but the resistance exercises help increase the localized muscle sensitivity to insulin. And this can also be a great factor in controlling diabetes. Resistance exercises also help with mobility limitations that can arise from diabetes complications later in life. So things like diabetic neuropathy, where this feeling of like walking on pins and needles, or loss of joint mobility, that can be helped later in life by resistance exercises and by flexibility exercises. So Glucosone is really an industry leader in this area. They incorporate those recommendations from the American Diabetes Association. So it really is a very mixed program, incorporating all of these different components. As for the study with youth, there was a large cardio component, I think largely due to the participants being at a beginning level, and with only doing once per week, there was limited degree to which we could advance their level. And so just starting at the sort of like bottom of the pyramid for physical activity with moderate intensity cardio exercises. And of course, we want to make it fun because kids are involved. And so the non-competitive games are good for that aspect.
Great. Here's this question's asking, at this point, do you believe or do you anticipate that the outcomes of the adult study could be generalizable to more diverse racial demographics?
So I think we're at that stage of, like I said, proof of concept in a narrow population with potential to expand to more diverse populations. I think we definitely need to think of our strategies. I think we use Facebook for social media recruitment because their ad feed system is very advanced. It's possible to pay to target ads to people just based on whether they have one diabetes related interest on their profile. Other social media like, and this diverts to Instagram also, so Facebook and Instagram work together on this. Snapchat, TikTok, YouTube, a lot of these other social media platforms do not have this feature available, at least that we've looked into so far. And so I've published a paper recently on Facebook utility for recruiting in one of my other studies, but basically it just really has ability to reach certain groups that are hard to reach. So in our case, it's been very helpful in reaching people with low activity levels, and then also getting a good representation from people who have suboptimal blood glucose control and BMI in the overweight to obese range. But it hasn't cracked that diversity issue yet. So we're going to need to look into ways to recruit this population. And then I expect we will need adjustments to the intervention also. I think there's a lot of work to be done.
So we did have a question. Someone's asking if you're still accepting participants for this study, and if so, how can somebody apply?
Oh, that's a great question. Unfortunately, we are just filled up our enrollment about a month ago. We'd be happy to include anyone on a waiting list for further studies that we will be offering hopefully soon.
Great. That's good to hear. Here's another question. Is there a risk stratification procedure in play for these studies? For example, associated comorbidities with type 1 diabetes or complications other than ketoacidosis? If so, what is the advice given to these patients?
Yes, that's a good question. We do have in the inclusion criteria that conditions that would significantly alter the exercise prescription, such as chronic renal failure or cerebral palsy or advanced diabetes complications, are excluded just because the exercises at this time are not geared to this group. So for this reason, everyone who joins the study has been cleared by a physician. They've passed the PAR-Q survey with contraindications to exercise. And so the advice provided is really just the very standard advice for exercise with diabetes.
All right, we have time for 2 more questions. The first one is more related to coaches and parents and the burden being on kids to learn how to manage their diabetes. How difficult is that when, for example, someone is playing a sport versus just engaging in an exercise bout, where a sport might have varying intensities and demands throughout a game, for example?
Okay, yes, so it gets much more complicated. A lot of if you read the consensus document that on exercise guidelines for diabetes shown here, a lot of the tips relate to things like, for example, if the exercise is between 60 and 90 minutes, what should be done. And in particular, there's a lot more adjustment made to the insulin dosing in the run-up before and during the exercise. Often supplementation of carbs will be recommended in the middle of the exercise bout. So it does get more advanced. Our real goal in the studies was to distill all that down. So for example, a group just targeting of adults targeting 30 minutes of exercise per day, we don't need to include that information about the 60 to 90 minute bouts. But certainly getting to a more advanced level, there's more advanced coaching that's needed. Glucosone does provide some of that. They do have some high active clients that they'll provide more advanced advice to. I think you also asked about the parent, the parent burden on this also, and that's, I think, parents do take an involvement in their youth managing diabetes. As the youth reach adolescence, it's a time of independence and greater self-dependence on the diabetes management. And even, for instance, in the team sport situations, they'll no longer necessarily, the coach will be aware that the teen has type 1 diabetes. They'll be filled out on a medical history, but the coach may just provide information such as, here's when the game starts, here's when we're going to be on the bus, here's when we'll have access to food, and the team will start to make their own decisions about dosing and management. So the coach and the parents will gradually take less of a role in that.
Great. And now, while we're asking Dr. Ash this last question, we're going to put up a slide so that you all will know how to register for the virtual New England chapter if you'd like to. Dr. Ash, do you have any websites or any resources that you would refer people to related to parents or coaches or athletes who want to be active with type 1 diabetes?
So I would definitely refer them to Glucosone. Really, glucosone.com. I can post that link. It's very affordable, personalized digital solutions for exercise with diabetes. And the American Diabetes Association also has good landing pages with general exercise advice.
Awesome. Thanks so much. This has been a great presentation by Dr. Ash. We really appreciate your time. We appreciate Dr. Gallo joining us today as well. It was really interesting to hear about the multidisciplinary work that you're doing, Dr. Ash, and the really, really cool, innovative technology work that you're folding into your exercise science work. So thank you again for a great presentation. We do encourage folks to register for the New England Regional Chapter. It'll be virtual this year, and it's coming up very soon. So please do it. Please do join. I think you'll get a lot out of that. And with that, we are going to end our webinar. We'll say a big thanks here internally at the ACSM office. We are socially distanced. There are just a couple of us here. So we're going to say thanks to Dr. Ash. We're going to end, and we'll see you all again in October.
Thank you. And thank you very much for having me on.